Hey guys, I welcome you all on my channel. First of all, pardon me for not posting any video almost for a month. It gives me an immense happiness in introducing you all with my favorite system, kidneys. So today I will be starting the renal system with IgA nephropathy. So why waste time in introduction and let's get started. IgA nephropathy, it is the most common cause for glomerulonephritis. Glomerulonephritis is nothing but it is the infection which is occurring in the glomerulus. Very basic terminology. It results in episodic hematuria. As the name suggests, there is IgA nephropathy, that means there is deposition of IgA. So it mostly occurs in males between 20 to 30 years of age. Mostly Asians are affected, 30% of Asians, and occurs in 20% of Europeans. So there is certain similarity between Henoch-Schönlein purpura and IgA nephropathy. Henoch-Schönlein purpura also named as IgA vasculitis. So there is this IgA deposition over there also. But of course, the difference is in Henoch-Schönlein purpura, it occurs in younger age group. There are preceding infections, there are abdominal complaints, and there is palpable purpura. This IgA deposition in the mesangium also occurs in chronic liver disease, then Crohn's disease, celiac disease, chronic bronchiectasis, idiopathic interstitial pneumonia, dermatitis herpetiformis, mycosis fungoides, ankylosing spondylitis, HIV infections, and Sjogren's syndrome. So I have made a mnemonic, you can make yours. Then there is this mechanism, that is innocent distant mechanism, wherein the mucosa associated lymphoid tissue, they are insulted or there is injury which is occurring. Okay? That will lead to the polymeric IgA production. This is actually produced by the mucosa, but in less number, or we say that there is this normal production, but there is defect in galactosylation that cannot be cleared by the liver, and so these antibodies, there is the antibodies production which is occurring against that of the polymeric IgA. So these immune complexes are deposited in the mesangium. So the kidneys are actually the innocent targets. So on the renal biopsy, we will see there is mesangial IgA deposits. There may be IgG, IgM and C3 deposits. So there is this postulated phenomenon, that is there is decrease in the renal clearance by the liver. There is increase in IgA production by the plasma cells. There is decreased receptors for the IgA. There is decreased mesangial clearance by IgA. So presentation will be, there will be macroscopic hematuria. So mostly whenever a patient has a gross hematuria, two things should come in your mind, that is this IgA nephropathy and we have sickle cell nephropathy. Sickle cell nephropathy not so common, okay, but IgA nephropathy. And of course there are other things, renal stones and renal papillary necrosis and everything. There will be microscopic as well as macroscopic hematuria in those. But whenever talking about gross hematuria, this should come in your mind. There will be proteinuria, there will be persistent microscopic hematuria. So during or immediately after a respiratory tract infection, there might be macroscopic hematuria. 5 to 30% of the patients have complete remission, but 25 to 30% they go into the renal failure. So we have certain which is Messi score. So it is mesangial hypercellularity, endocapillary hypercellularity, there is segmental sclerosis, there is tubular atrophy, and there are crescents. So crescent, that means it has an RPGN presentation. So one of the causes for RPGN and segmental sclerosis. So if there is an endocapillary hypercellularity seen, that means that this is an active disease. So in that, steroids may be given. So steroids have to be given in if the patient presents with a nephrotic syndrome, it has an RPGN presentation, endocapillary hypercellularity, proteinuria which is more than that of 1 gram per deciliter, despite of 6 months of conservative treatment. GFR is more than that of 50 ml. That means the kidneys could be saved. Then only we plan for steroids. AC inhibitors, ARBs, of course, for the proteinuria, salt restriction, protein restriction. Okay. The prognostic markers at presentation. Poor prognosis seen in hypertension, renal impairment, it depends upon the severity of proteinuria, smoking, hyperuricemia, when there is gross obesity, long duration of preceding symptoms, increasing age. Histopathologic wise, we have poor prognosis when mesangial hypercellularity, endocapillary proliferation, glomerulosclerosis, tubular atrophy, interstitial fibrosis, capillary loop of IgA deposits, then there are crescents. Good prognosis when there is recurrent macroscopic hematuria. So the question may say that the patient has recurrent macroscopic hematuria. So this is associated with a good prognosis or a bad prognosis. So it is a good prognosis. Why? Because the patient would be aware of the urine color and he would come to you, and then you would investigate, and then you would come to the diagnosis. Other than if he has having only microscopic hematuria, or he is even having decrease in urine output, the patients are not so aware of it. They would be noticing it after 15-20 days or even after months. So this plays a very important role, and there is no impact on prognosis, uh, gender, male or female. Then if there is any serum IgA levels, so how much serum IgA levels or intensity of the IgA deposit, it doesn't matter. Okay. So this was for IgA nephropathy. Then we have something which is actually a small vessel vasculitis. So small vessel vasculitis, that is also contributing for the glomerular nephritis. Okay. So why am I starting with this small vessel vasculitis or IgA nephropathy, these causes for glomerulonephritis? Because the other causes like that of post-structural glomerulonephritis or any of the other kidney disease like that of nephrotic syndrome, we are all aware of it. We have the knowledge, we have been discussing it through the decades, but these things are something which are missed, and I want them to be to make you familiar with all these terminology and all these symptoms, because patient will be presenting the similar complaints to you, and you will be doing urine routine and you will be investigating. Of course, in the government setup, biopsy is rarely done, but whenever if the biopsy is done, you should be able to locate what is the disease, where is the disease, what it actually, if there is a segmental sclerosis, what it means. Okay. So small vessel vasculitis. So there is antiproteinase 3 and anti-MPO. We have two antibodies, right? So whenever there is antibodies against the antiproteinase 3, so there is Wegener's granulomatosis C. Okay. And whenever there is an antibodies against the MPO, that means there is microscopic polyangiitis or Church-Off syndrome. So remember M for M. So these are produced by T cells and the antibodies, and they cause damage to the vessel walls. So that is called as small vessel vasculitis. Okay. So treatment wise, patients are given cyclophosphamide, patients are given plasmapheresis. Plasmapheresis seen in CNS vasculitis, plasmapheresis done in pulmonary hemorrhage whenever patient suffers with pulmonary hemorrhage. So it responds to the plasmapheresis. So of course steroids have been given. So we'll see in depth what is the treatment. This is the highlight that the urgent treatment is required, and we actually tend to miss these patients. So there is vasculitis, that means there will be neutrophilic infiltration with that of fibrinoid necrosis, and there is leukocytoclasis. So coming to the Wegener's granulomatosis, mostly 40s to 60s, right? More than that of the 40 years, and males and females are both are affected equally. Antiproteinase 3 antibodies, and there is this triad. This triad says that there is an RPGN crescent. Okay, there is this in and kidneys, and then there is vasculitis, and of course there would be the sinusitis, the otitis media, the ear infection, there is epistaxis, okay, there is hemoptysis, there is cough, there is rhinorrhea, so subglottic stenosis. So this is the case may be presenting you with all these symptoms. And the medium vessel which is involved, causing mononeuritis multiplex. There is episcleritis, there is arthralgia, there is purpura or petechiae. X-ray may be showing nodules, persistent infiltrates, and there can be even cavity. And biopsy will be saying there will be a granuloma, but it is a non-KCAD. So whenever there is an active disease, there will be segmented necrotizing glomerulonephritis. So the purpura which is seen over here, we said that there is palpable purpura, but it is a non-thrombocytopenic palpable blanching purpura. Okay. Then we have microscopic polyangiitis, which is opposite to pan. You can refer to the pan in the video. Mostly it has no granuloma, glomerulonephritis which is present, pulmonary involvement is seen, and there is Pianka. Now this Church syndrome, we only know there is eosinophilia in this, but there is much more in this. There is eosinophilia, of course, there is this is an allergic condition, there is hypergamma there is increase in Ig levels. But did you know there is also focal segmental necrotizing glomerulonephritis, so we can be confused with that of Wegener's. But presentation, we have allergic rhinitis or allergic cough like that. Even Wegener's have that. So only distinguishing will be Ig levels and we say the eosinophilia. So there are three states. There is prodromal state, that will be asthma and allergic condition. There is eosinophilic state and there is vasculitis state. So the vasculitis which will be affecting, causing the eosinophilic gastroenteritis, there will be eosinophilic myocarditis, there is vasculitic neuropathy. So the CNS is involved, the heart is involved, and the GIT is involved. So gastroenteritis, myocarditis, and there is neuropathy. So eosinophilic myocarditis is the most common cause of death. Patient is administered with steroid, and there is mepolizumab. Okay. The medium vessel involved as so in Church syndrome causing M4M mononeuritis multiplex. Okay. Coronary involvement is seen. Okay. Then there is cerebral involvement also. There is mononeuritis multiplex. There is mesenteric vasculitis. There are, so whenever the medium vessels are involved, there will be ulcers, there will be gangrene, there will be nodules, there will be levator reticularis. Okay. If there is a small vessel involved, there will be only purpura, petechiae, like that. So small and medium vessel. Okay, that is Church syndrome. There is medium vessel is involved in this. So whenever patient presents with the symptoms like any triad, or we suspect the patient with increase in Ig levels or something, cough, and that is recurrent allergic cough, patient is given symptomatic medication but is not benefiting, then we do an immunofluorescence, then we have B ANCA and C ANCA. Now if the patient is having a C ANCA, that is cytoplasmic ANCA, or we have a perinuclear ANCA, so there will be ELISA will be saying antibodies, and then we have mostly the percentage is like Wegener's granulomatosis will have 70%. It is mostly seen that if the C ANCA is present, that means 70% of time it is the Wegener's granulomatosis. 40% can be microscopic polyangiitis, 20% have renal vasculitis, and 5% can have EGPA. So the percentage of antibodies which can be present in the, that is C ANCA, which present in these disease. First of all Wegener's, then microscopic polyangiitis, then renal vasculitis, and then we have EGPA. Now if it is actually antibodies against that of the MPO, then the MPO, if it is a positive, that is called as typical one. If it is a negative, then it is atypical one. So first of all, when renal vasculitis should come in mind, then we have microscopic polyangiitis, then we have EGPA, Wegener's come to be the last, and then we have the Good-Pescher syndrome. So this is the newer added thing. Atypical involves Seira. I have made a mnemonic. Autoimmune hepatitis, primary sclerosing cholangitis, infective endocarditis, rheumatoid vasculitis, Inflammatory bowel disease, cystic fibrosis. So cystic fibrosis, primary sclerosing cholangitis, infective endocarditis, rheumatoid vasculitis, autoimmune hepatitis, inflammatory bowel disease. Okay, so if the P ANCA and MPO, if the MPO is if the P ANCA has antibodies against the MPO and MPO is positive, it is typical. If it is not, then it is atypical. If it is MPO, then the first thing that should be coming is that renal vasculitis, then microscopic polyangiitis, then EGPA, then Wegener's, and then acute pescius. In this, we have SIRA, that is cystic fibrosis, primary sclerosing cholangitis, rheumatoid vasculitis, autoimmune hepatitis, inflammatory bowel disease. So, in case of the C ANCA, one more thing, the drugs. The drugs also can be one. Sorry, in case of MPO, one more thing that can be seen is this: hydralazine, propylthiouracil, minocycline, or levamisole. So the biopsy will be having leukocytoclastic vasculitis with or without the necrosis. There will be fibrinoid necrosis, and there can be leukocytoclastic vasculitis. So the treatment of Wegener's and polyangiitis is more or less similar to SLE. We have IV MPS given, okay, so that is given for 3 days, okay, followed by that of the oral prednisolone. So this oral prednisolone should be tapered by that of 8 weeks, and then along with the cyclophosphamide, that is 15 milligram per kg IV for the mostly 10 doses are given, or oral cyclophosphamide 2 milligram per kg can be given. In case of relapse, R4R rituximab, okay. Maintenance, there should be a low dose of steroid along with azathioprine. Plasmapheresis is done in case of CNS vasculitis or whenever the creat is more than 5.5 in case of pulmonary hemorrhage, that is seen in good pastures mostly, okay. So this would be the treatment, mostly the plasmapheresis one, till we come to the conclusion that the patient is having the any of the vasculitis. This plasmapheresis is not done. Mostly the dialysis part has to be done because patient lands up into CKD. So very vigilantly we have to act. Very vigilantly we need to see for the symptoms of the patient. The only motto to understand this topic was, I had come across a patient. I had to present a clinico-pathological case, and the patient had first of all the symptoms of the Wegener's, but then as the symptoms had been produced since till like for 1 month, 2 months, the patient presented with more likely like that of the pan, as the biopsy for the Wegener's was done, and it did not reveal any of the Wegener's pathology, and it was more like that of the pan. Okay, so I hope you enjoyed this topic, and I will continue with the renal system. Thank you.